bedside pulmonary function test. So by definition, pulmonary function test is a term used to indicate a group of studies or maneuvers that may be performed using standardized equipment to measure lung function. Pulmonary function test can include a simple screening uh, bedside pulmonary function test or a screening right spirometry or a routine spirometry or other lung volume measurements and diffusion capacity for carbon monoxide, arterial blood gas analysis, capnometry, pulse oximetry, and other cardiopulmonary exercise testing, sir. The indications for pulmonary function test are either diagnostic, monitoring, or the public health. The diagnostic test to evaluate the patients who are having symptoms, either dyspnea, wheezing, cough, orthopnea, or the signs like diminished breath sounds, overinflation, expiratory slowing, or the cyanosis, or with the chest wall deformity, and to measure the effect of the disease on pulmonary function, either obstructive or restrictive, and to screen the individuals at risk of having pulmonary diseases like smokers and occupational health hazards such as asbestosis, to assess the preoperative risk to have pulmonary disease, obese patients, or major abdominal surgeries, thoracic surgeries, or patient having history of smoking, cough, or wheezing, or as a part of uh, to assess the prognosis in the idiopathic pulmonary fibrosis, lung transplant, and to assess the health status uh, before the physical activity programs, or monitoring of the patients after bronchodilator therapy or steroid treatment for asthma, interstitial lung disease, or to describe the course of the disease in obstructive disease, interstitial lung disease, cardiac disease, and neuromuscular diseases. Other than that, we can do epidemiological surveys, and it is the medical legal importance in occupational health hazards, or deriving reference equations for the interpretation of the pulmonary function test according to various age, sex, race. The requirement for a good pulmonary function test are: it should be lack of artifacts induced by coughing or glottic closure or equipment problems, mainly the leak problems. The satisfactory start to test is to without hesitation, and the procedure is to be properly explained and trained. The observer is to be adequately trained, and the satisfactory exhalation with 6 seconds of smooth continuous exhalation or a plateau in the volume time curve, or at least 1 second or a reasonable duration of the exhalation. And the up to 8 efforts are allowed, otherwise the patient will have exhaustion of respiration, sir. And the contraindications for the PFTs are hemoptysis of unknown origin, pneumothorax, recent myocardial infarction, and unstable angina pectoris, thoracic or abdominal or cerebral aneurysms, recent abdominal or thoracic surgical procedures, recent eye surgeries, recent history of syncope. The limitations of the PFT are the accuracy of the test depends on the well-trained technician also, and there are some variability from the normal predictive values, and the pulmonary function test mainly relies on the patient too. The patient should be properly trained. Proper training of the patient is required. Sir, moving on to the pulmonary function test, we are starting with spirometry. The spirometry is one of the most commonly performed pulmonary function tests, which measures the rate at which the lung changes volume during quiet and forced breathing maneuvers. It can be measured. It can be measured in two forms. The volume measuring spirometers are there, and flow measuring spirometers are there, sir. The volume measuring spirometers are mainly which measures the volume in a against the time, and we obtain a volume time curve, and The spirometers which are commonly used for these are the water sealed spirometers, dry sealed spirometers, bellows spirometers, and rotor spirometers. And for the flow derived curves, we have differential pneumatometer, thermal anemometers, and ultrasonic sensor anemometers. And regarding the spirometry, there are mainly static lung function test and dynamic lung function test. The static function tests are volume related. And in the static function test, we have 4 volumes and 4 derived capacities. The 4 volumes are inspiratory reserve volume, tidal volume, expiratory reserve volume, and the respiratory residual volume. And the 4 derived capacities are inspiratory capacity, functional reservoir capacity, vital capacity, and the total lung capacity. In the dynamic, which are time related, we have force expiratory volume in 1 second, FEV1, and peak expiratory flow rate, FPFR, and maximal breath capacities. So the spirometry values mainly depends upon the age, gender, body size, build, and the race of the patient. The values also changes with the position which it is measured. It decreases with the supine position and increases with the erect posture. Coming to the volumes, the tidal volume, the volume of air inspired and expired during normal quiet breathing. It is normally 500 ml, that is 8 ml per kg. The minute volume is the tidal volume into the respiratory rate, which is approximately 3.7 to 20 liters per minute. And another volume which is measured is the alveolar ventilation, that is the tidal volume minus the dead space ventilation into the respiratory rate, which is the actual volume which enters the alveoli, and it is affected by the deep anesthesia and the respiratory muscle depressants. Next is the inspiratory reserve volume. It is the maximum amount of air that can be inhaled after a normal tidal volume inspiration, that is normally 3000 ml. The expiratory reserve volume, that is the maximum amount of air that can be exhaled from the resting expiratory level. The normally it is 1100 ml. The inspiratory capacity, that is the maximum amount of air that can be inhaled from the end of the tidal volume, that is inspiratory reserve volume plus the tidal volume, which is 3500 ml. The residual volume. The residual volume is the air remaining the lungs at the end of the maximum expiration, which is normally 1200 ml. The inspiratory, the residual volume, it is not routinely measured in the spirometer. There are specialized techniques which are used for the residual volume measurements, such as the gas dilution techniques, the nitrogen washing technique, helium dilution technique, and the body plethysmography. The significance of the residual volume is the volume that is remaining after the force end of the force expiration, and it depends on the two factors. The limitations of the chest wall excursion and the smaller airway collapse. In restricted lung pathologies, the residual volume is determined by chest wall compression by the muscles. In the obstructive diseases, the collapse of the terminal airway prevents the distal air from the escaping the lungs, and thus it influences the residual volume. The residual volume and the total capacity are commonly increased in the chronic obstructive pulmonary diseases, but are normal in patients with the asthmatic patients. And next, moving on to the functional residual capacity. It is the volume of air remaining the lungs at the end of the tidal volume expiration. That is, functional residual capacity, it is equal to expiratory reserve volume plus the residual volume, that is normally 2300 ml. So the significance of the functional residual capacity, it is balanced by the outward elastic forces of the relaxed chest wall and the inward elastic recoil of the lungs, and it is usually 40 to 50% of the total lung capacity. and it increases with reduced lung elasticity and decreases with the increased lung coil, and it is also affected by the posture, and it is temporarily increased in the bronchial asthma or over inflation of the lungs after thoracotomy, and with emphysema with air trapping and chronic bronchitis, and it is FRC is decreased after induction of the anesthesia and after post-operative abdominal surgeries, and the FRC is decreased in the pediatric and the pregnant patients, and with large intra-abdominal masses under anesthesia. So the pre-oxygenation prior to induction of anesthesia is to replace the FRC with 100% oxygen, which helps in delaying the desaturation of the apneic patient during intubation. Next, moving on to the total lung capacity. Total lung capacity is the volume of air in the lungs after maximum inspiration. That is, total lung capacity is equal to inspiratory reserve volume plus tidal volume plus the functional residual capacity, that is the expiratory reserve volume plus the residual volume. It is normally 5,800 ml. Then the vital capacity. Vital capacity is the maximum volume of the gas that can be expelled from the lungs by a forceful effort following a maximal inspiration. That is tidal volume plus inspiratory reserve volume plus expiratory reserve volume. It is normally 4,600 ml. The pre-oxygenation can be done for 2 to 3 vital capacity breaths, or that is equal to the 2 to 3 minutes of the tidal volume breathing. Vital capacity is affected by changes in the muscle power and pulmonary diseases, especially the restrictive diseases, space occupying lesions in the chest, abdominal tumors, or abdominal plain or abdominal splinting, and altered posture. Altered posture, especially the Trendelenburg position, 20 degree reduces the vital capacity by 14.5 percentage, lithotomy by 18 percentage, left lateral position by 10 percentage, right lateral position by 12 percentage, and bridge in the dorsal position by 12.5 percentage, and in prone position, vital capacity is reduced by 10 percentage. If the vital capacity falls 3 times below the tidal volume, then the effort of the patient, that is airway, the effort which is necessary to clear the airway secretions is reduced. So a patient needs a support to clear the airway and the secretions, which is less than 1.5 liters. And clinical significance is the restrictive lung diseases are classified based on the total lung capacity, which is based on the predicted total lung capacity. It can be classified as mild, more than or equal to 70 percentage, moderate 70 to 60 percentage, severe less than 60 percentage. And based on the spirometry, predicted vital capacity, the mild is more than or equal to 70 percentage, moderate 60 to 70 percentage, moderately severe 60 to 50 percentage, severe 50 to 34 percentage, and very severe less than 34 percentage. The causes for the restrictive pattern are the primary lung parenchyma pathologies and atelectasis, fibrosis, pulmonary edema as in secondary to the congestive cardiac failure, or effusion, or extrapleural pathologies such as displacement of the chest wall, ascites, pregnancy, severe pain leading to the splinting of the abdomen, obesity, kyphoscoliosis, and severe burns contractures, scleroderma, and neuromuscular problems such as phrenic nerve palsies. And coming on to the small diagram. Sir, am I visible, sir?
Yeah, it's visible, but very small. As you said, it's a small diagram. It's quite small enough. Yeah, this now most of the students would have seen this sort of diagram in the books. So that's good.
Then,
Can go ahead.
sir, then moving on to the dynamic lung function tests. Sir. The dynamic lung function tests are to be measured in a relaxed, comfortable, and procedure to be well explained. The nose to be clipped, and disposable mouthpieces are to be used. And best of three after training of the patient is to be taken. The data is entered according to the height, weight, BMI, sex, and the race of the patient. It is the report is given as the actual value, the predicted value for the patient, and the percentage obtained by the patient's values. First, let's discuss about the forced expiratory volume in 1 second. It is the percentage of the forced vital capacity which can be forcibly expired as rapidly as possible in 1 second after maximal inspiration. It is basically the forced vital capacity tracing, uh, the tracing, sir. In this, we have in x-axis we have time, and in y-axis we have the volume in the liters. Time is measured in the seconds, and we have a graph. Normally, it is 80% of the forced vital capacity, and it is mainly depend on the voluntary effort of the patient, and it is decreased in chronic bronchitis COPD, and it is an indirect measure of the maximal breath capacity. And according to the FEV1, we have gold staging for the COPD, which is mild is equal to 80%, moderate 50 to 79%, severe 30 to 49%, and very severe less than 30%. Next is the FEV1 by FVC ratio, which is the percentage of the total FVC expelled from the lungs during first second of the forced exhalation. And we have ATS guidelines for obstructive lung diseases based on this. If the FEV1 FVC ratio uh, is 100%, it is considered normal. If FEV1 FVC ratio is less than 100% but more than 70%, it is mild obstruction. And less than 70% but more than 60% is moderate obstruction. Less than 60% but more than 50% is moderately severe obstruction. Less than 50% more than 34% is severe obstruction, and less than 34% is very severe obstruction. And next is the peak expiratory flow rate, which is the maximum flow rate achieved during the forced vital capacity maneuver after full inspiration with maximal expiration. Normally, it is 450 to 700 liters per minute in males and 300 to 500 liters in females. It is measured by drawing a tangent to the steepest part of the total vital capacity curve. And it is measured also by the Wright's peak expiratory flow meters. And PFR reduced in chronic bronchitis, asthma, emphysema, and restrictive diseases. Next is the forced expiratory flow. It measures how much air can be expired from the lungs in the forced vital capacity curve. Actually, the forced vital capacity curve is split into 4 quartiles. First 25%, 25 to 50%, 50 to 75%, and 75 to 100%. In this, the first 25% is the amount of air forcibly expelled in the first 25% of the forced vital capacity curve, and which is mainly the patient effort dependent, and it is not considered. The middle half of the curve, which is the 25 to 75%, is the clinically important curve, and it is reduced in the obstructive diseases, and it is patient independent. It mainly measures the small airway diseases. And maximal voluntary ventilation. It is the total volume of the air moved in and out of the lungs in 1 minute, which is approximately 100 to 120 liters per minute. The patient breathes in and out of the lungs as rapidly and fully as possible for 12 to 15 seconds, because the patient cannot breathe for one whole minute. So it is measured for only 12 to 15 seconds, and it is multiplied by 3 to 4. 3 or 4. It is difficult for measuring in a ill or a post-operative patient, and it reflects the status of the respiratory muscles, compliance of the thorax, compliance of the lung-thorax complex, airway resistance, and it is a comprehensive test, and it is effort dependent. Next, we are coming to the flow-dependent spirometries, which are mainly the flow volume loops, and it is a graphic analysis of the flow at various lung volumes subject to the subject inhales fully to the total lung capacity, then performs a forced vital capacity maneuver. The maximum inhalation as fast as possible. The flow and the volume are depicted in the plot, in which the flow is depicted in the y-axis and the volume in the x-axis. And the clinical significance of the curve is it can detect whether the patient is having obstructive disease or a restrictive disease based on the shape and size of the curve. It also helps in identification of the site and type of the obstruction. Example, tracheal stenosis, intrathoracic obstruction, or whether it is a tracheal tumor. Next is the closing capacity. Closing capacity is the lung volume at which airway in the dependent areas of lung begin to close occurs. It is measured if the closing perhaps the whole of the normal
Your audio is breaking.
will not be fully oxygenated and PaO2 will fall. The closed capacity of the lung is equal to the residual volume plus the closing volume. The closed capacity is seen in the it is increased in the smokers and rapid IV transfusion and left ventricular failure following myocardial infarction, obesity, chronic bronchitis after surgery, and it is a measure of the post-operative hypoxemia. The PEEP helps in the
No, your audio is stopped.
disease, whereas in the restricted disease, normal or slightly. The residual volume is increased in the obstructive disease and it is decreased in the restrictive lung disease. The FeV1 or forced vital capacity ratio is decreased in the obstructive diseases, whereas it is normal or increased in the restricted lung diseases. And the maximal breath capacity is decreased in the obstructive disease, whereas in restricted disease it may be normal. So rather than the spirometry, we have the respiratory.
Dr. Pavithra, your audio is not continuous. It is breaking once in a while.
Is no,
Your audio is breaking.
lungs. It is the difference between the atmospheric pressure and the alveolar pressure. It is mainly the airway resistance and the airway conductance. It is mainly used to identify the bronchoconstriction and the bronchodilation. The compliance. The compliance mainly the volume change per unit change in the pressure, that is 200 ml per centimeter H2O in a normal lung. The total respiratory compliance is equal to the lung wall compliance plus the chest wall compliance, which is normally 70 to 80 ml per centimeter H2O. The static compliance is the ideal level of the PEEP, which is to be given in the ICU. The compliance are mainly static compliance and dynamic compliances, sir. Next, coming to the diffusion lung capacity. The diffusion lung capacity of the lung for the carbon monoxide is measured is a measurement of the transfer of the carbon monoxide molecules from the alveolar gas to the hemoglobin of the red blood cells in the pulmonary circulation. Then it is the hello sir.
Yeah, go ahead. We are hearing.
The most commonly used method for measuring the diffusion lung capacity is the single breath technique. In this, the patient inhales a known volume of the test gas, which contains 10% helium, 0.3% carbon monoxide, 21% oxygen, and remainder nitrogen. The patient inhales the test gas and holds the breath for 10 seconds, and the patient exhales to the anatomic death phase, and subsequently the alveolar sample is collected and the DLC was calculated, sir. And there is, according to the diffusion capacity, it can be mild, which is more than 60% of the predicted, and moderate 40 to 60%, and severe less than 40%. The condition in which the diffusion lung capacity is affected are the obstructive lung diseases, emphysema, example emphysema, cystic fibrosis, parenchymal lung diseases, which are interstitial lung diseases, fibrogenic dust and asbestosis, biological dust, and drug reactions, example amiodarone, bleomycin, and sarcoidosis, and pulmonary lung involvement in the systemic diseases such as SLE, systemic sclerosis, and in cardiovascular diseases such as acute myocardial infarction, mitral stenosis, primary pulmonary hypertension, pulmonary edema, and pulmonary thromboembolism, fat embolism, and other diseases such patients who are in chronic hemodialysis and smoking and pneumonia. Other than this, we have the cardiopulmonary exercise testing, 6-minute shuttle walk test, and staircase test, and other functions are the arterial blood gas analysis, capnometry, pulse oximetry, sir. Sir, moving on to the bedside pulmonary function test, sir. Brief note on. So the bedside pulmonary function tests are subrasive breath holding test, in which the time for which a person can hold his or her breath after a deep inspiration is calculated. It is also called as the voluntary apneic pause test. It is mainly used for assessing the cardiopulmonary reserve of the patient. The normal time is 25 to 30 seconds, and if it is less than 20 seconds, it is limited or decreased, and 10 to 50 seconds is a very poor reserve, and it can be taken as a contraindication for the elective surgery. And the significance of the breath holding test is the time taken and the vital capacity approximately which it coincides are given, sir. The 25 to 30 seconds of breath holding test coincides with the 3500 ml, which is the normal vital capacity. 20 to 25 seconds corresponds to 3000 ml. 15 to 20 seconds corresponds to 2500 ml. 10 to 15 seconds corresponds to 2000 ml. 5 to 10 seconds corresponds to 1500 ml of the vital capacity. Next, moving on to the Schindler's mass blowing test. In this, a lighted candle at the level of the patient mouth, and the patient should be sitting, mouth wide open. There should be no pursing of the lips, no head tilting, and the head chin should be supported, and there should be no air movement in the room. The minimum distance of the patient's ability to blow it is taken into consideration. The normal is 25 centimeters, and if it is less than 15 centimeters, there is reduced peak expiratory flow. And if the distance measured corresponds with the maximum breath capacity. If it is 9 inches, it is 150 liters per minute of the maximum breath capacity. 6 inches corresponds to the 100 liters per minute of maximal breath capacity, and 3 inches corresponds with the 50 liters per minute of maximal breath capacity. Next is the auscultation over trachea test or the Steth test, in which the forced expiratory time duration is measured. Normal is 4 seconds. In COPD, it is more than 4 seconds. Next is the cough test, in which deep breath followed by a cough is done. The ability to cough, the strength and the effectiveness is measured. The inadequate cough uh, is there if the forced vital capacity is less than 20 ml per kg. That is corresponds to the forced expiratory volume per second less than 15 ml per kg, or the peak expiratory flow rate less than 200 liters per minute. A wet productive cough or a self-propagated paroxysms of coughing uh, states that the patient is susceptible for a pulmonary complications postoperatively. And next is the Debono's vessel, which we don't use now, sir, but it is there. It measures the peak expiratory flow by the threshold activation. There is a plastic tube with a kettle type vessel at the one end and a cardboard mouthpiece at the other end, and there are leak holes at the side, which it's having a mouthpiece. The patient blows, it produces a sound which increases in the aperture size of the leak hole, sir, at a higher flow rate. And the other tests which are used bedside are Wright's peak flow meter, which measures the peak expiratory flow rate. The value is less than 200 liters per minute, will have an impaired cough efficiency, and the normal peak expiratory flow rate in males are 450 to 700 liters per minute and females 300 to 500 liters per minute. The others equipments can be used bedside are the dial type spirometer and a bedside pulse oximetry, sir. Uh, Done, sir. Thank you, sir.
Yeah, done. Very good. That's a very exhaustive and very nice presentation.
Thank you, sir.
But a few corrections I think we have to make in that. One is you said tidal volume is inspiratory and expiratory flow of 500 ml. It's not both. It can be inspiratory tidal volume or expiratory tidal volume. Okay? It is not a combination of both inspiratory and expiratory. So we breathe in 500 ml of air and then breathe out 500 ml of air. So that at quiet breathing, it is what is called the tidal. Why it is called tidal volume? Any idea, Pavithra? Why it is called tidal
It has
volume?
a inspiratory and expiratory components which
Hmm.
looks
So when you trace
mm,
it, how does it look like?
it looks like a tire.
It looks like the tide of a sea, isn't it? So that is why
Yes.
it is wavy pattern. The wave-like pattern is so the you get a inspiratory tidal volume and an expiratory tidal volume. So if you go on tracing it, it goes like a wave of a sea. That is why it's called a tidal volume. And vital capacity is called vital because, as you rightly said, it is the main effect. The which is function is to produce an effective cough to clear any unwanted secretions or foreign body entering. Unless you have a good cough ability, you will not be able to. We will all be drowning in our own secretions. That's what my professor used to say. If we don't have a normal vital capacity, many patients not having a normal vital capacity will drown in their own secretion because we won't be able to clear the collections. And the bedside lung function test were all the starting point of pulmonary function test. Before the invention of the lab-based equipments which could measure the various volumes and capacities and both static and dynamic lung functions. The clinicians were using only the bedside lung function test, mainly to discriminate or find out the difference between an obstructive and restrictive airway disease. So patients who had obstructive airway disease, they had obstruction to the airflow at the air passage level, like the small bronchioles and bronchi, they had obstruction. whereas restriction is mainly for prevention of the expansion of the alveoli by the outside forces or the intrinsic deficiencies in the lung parenchyma. It is not connected with the air passage. So whatever volume that could be expelled or forced out could be done in restrictive airway disease, whereas it was reduced, and the speed with which it could be expelled out also is reduced in obstructive airway disease. That is the main reason why they did that, what is called the blowing the till and auscultation over trachea. All these things are mainly to find out the presence of obstructive airway disease. But till today, one bedside function test which is quite useful in our clinical practice, which I still use in my way of assessment of patients, is the breath holding test. That is a very, very valuable test with which you can find out uh, what is the integration between the cardiac function and the respiratory function. So we call it as a cardiorespiratory reserve. And this, as you said, if minimum should be at least 20 seconds. Patient should be able to hold the breath for at least 20 seconds. And you mentioned that it is dependent on the vital capacity. More than that, it is dependent on the FRC also, because during breath holding, it is the FRC which is going to contribute to the oxygenation of the patient, because there is no movement of air during the breath holding time. So if your FRC is plus your vital capacity both are good, then the patient will be able to hold for a longer time. Athletes and people who do regular exercises, they will be able to hold breath for even 1.5 to 2 minutes. That is 60, 90 to 120 seconds also. And because it is the, what is the reason for the breaking of the breath holding?
Sir,
Why it
it
is?
is measuring the apnea time of the patient, how much time he can uh, uh, maintain his oxygen saturation without respiration.
Oxygen saturation. Why we are not able to hold it beyond a certain time? Anybody, when we try to hold a breath, even with a normal lung, we are not
Yes, sir.
able to hold it for more than a minute or 1 minute and a half
Sir,
at the most.
our
Why?
CO2 rises, which is
Ah,
activates the
yes,
chemoreceptors and it activates the respiratory drive.
excellent. That is the main reason. So there is we are not eliminating the carbon dioxide because we are not breathing out. And oxygenation is taken care by the FRC, which is still there. So the accumulation of CO2 stimulates the respiratory center, and also the diaphragm is only partially under voluntary control. Beyond that, it is a muscle which has got its own inherent contractility power also. So because of these two factors, the diaphragm is not fully what is called involuntary muscle. It is partially voluntary and majority involuntary. And the second reason is CO2 is not eliminated, and that is stimulating the respiratory center to cause a person to initiate the respiration. And uh, have you ever seen a person holding the breath, breaking that breath holding at the end? How will they breathe? They will just come out with a blow like that. And because they have been holding all the air inside. So they will have to forcefully expel that out and bring back the CO2 to normal level. And within a few breaths, it will all settle down. So breath holding test is still a very valid and useful test. And when you do the 6 minute walk test, you can use your pulse oximeter to assess whether the uh, saturation is maintained after this exercise. In cases of severe lung diseases, the saturation goes down after they do the 6 minute walk test. So it is always better to attach a pulse oximeter and measure the oxygen saturation before starting the exercise, and then at the end of 6 minutes you watch the saturation. If it goes down to less than 90, that means there is some problem with the lung of the patient. And in the exam, Viva especially, you may be given a PFT report, which will show you the FEV1, FEC, and PLC, all these values, and you will have to identify whether it is a simple restrictive airway disease or a obstructive airway disease or a mixed disorder. Sometimes you may have both a obstruction and restriction in the same patient.
Yes, sir.
So you will have to find out what type of disease it is, and you must look for the post bronchodilator therapy values also in that. When you are asked to interpret that PFT values, you must always look at the post dilate for bronchodilator therapy value and see how much the improvement is there or no improvement is there. And what is the importance of that post bronchodilator therapy values when you interpret the
Sir,
PFT?
in bronchodilator therapy, we give 400 micrograms of a short-acting beta-2 agonist or 160 milligram of the anticholinergic, and we see the response of the patient. And if the FEV1 improves more than 12 percentage or 200 ml per minute, then it is a response to the bronchodilator therapy, sir.
So that note that drug should be specifically noted down so that in case intraoperatively you get to see a bronchospasm and then airway obstruction happens, you can use that same drug through the endotracheal tube for local effect and produce a bronchodilation. So that is the purpose of that bronchodilator therapy. So normally they mention what drug they are using also, and as a majority of our patients with COPD nowadays, they all use the inhalers. They have used the metered dose inhalers are available. So various combinations are also available. So they use beta 2 agonists, short acting, long acting, or the LABA, LAMA. All these things are all available now. So so when they go for pulmonary function test, they may use a variety of drugs also and see which one acts as the best dilator and then make a report on that. So we have to keep a note of that so that we can use them in case we end up with a problem of bronchodilation. And ultimately, arterial blood gas analysis is the ultimate test to find out what is exactly the pulmonary function is doing, whether it is adequately oxygenating the patient and carbon dioxide is getting removed or not. And so, starting from the pH in chronic COPD patient, what will you find? What will be the reading like? Can you give an
Sir,
imaginary or arbitrary values for a chronic COPD patient? How will you
sir,
find the pH to be?
the pH will be around 7.28 to 7.32,
Hmm,
less than 7.35.
hmm. So they will
And
be in
PCO2 will be higher, sir, on the higher side.
so they will have a chronic hypercarbia, but the pH would have been compensated by elevation of the bicarbonate. Okay, because they are in chronic respiratory acidosis. After a
Yes,
period of time, body compensates by increasing the bicarbonate value and try to get back the pH within the normal range of 7.35 to 7.45. So if you find the pH normal, CO2 slightly low, PCO2 elevated, bicarb elevated, it is a chronic respiratory acidosis, well compensated. On the contrary, if the pH is 7.2, as you said, with a hypercarbia, it is an acute condition. It has not been compensated. And on the contrary, and one more thing, if the bicarb is not elevated, say more than 26, and it is only 18 or 16, there is an added metabolic acidosis also in that patient. So that is a much more dangerous condition. So in a patient with COPD, you first look at CO2 and it will be always elevated. Then you look at pH. it is within normal range, it is well compensated. So you look at the bicarb, it will also be elevated to make the pH come back to normal. And on the contrary, if the pH is low and bicarb is also low and CO2 elevated, it is a mixed disorder of both respiratory and metabolic acidosis. So this is a way you interpret that, and this will be ultimate thing to decide whether you go for this or not. And she mentioned what are all the indications why we want to do the PFT. And one more reason for doing the pulmonary function test, especially in thoracic surgery, we can also decide whether the patient can be extubated after a lung resection on the table, or whether they will need only some supplemental oxygen for a few hours, or whether they have to be mechanically ventilated for a few hours or days before you think of extubation. So that also can be calculated using the pulmonary function test. And so that was a good presentation by Dr. Pavithra.
Thank you, sir.
You can circulate your answer to other colleagues so that they can all have a look at that, so it can be used easily.